Welcome back to the PFC Podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC Podcast. This is Dennis, and today I'm with Jason. How are you doing today?
I'm doing well. Thank you, Dennis.
Hey, well, I really appreciate you coming on. I saw your presentation at SOMA, and I thought it was a very good presentation. And I invited you on because I want to pick your brain about your experiences and how maybe we can replicate that in our own services or education. So if you wouldn't mind, maybe just do a real quick introduction of yourself.
Yeah, so I graduated from medical school in '99 and went to residency. Graduating general surgery residency in 2004. I did 9 combat deployments with the United States Army, 7 of those within the special operations community. After that, I've done a number of mission trips to different locations, probably operating in over 11 countries total, many of those in conflict areas and war zones.
All right. Well, you're definitely the perfect guy to talk to about this because just my experience, FSTs, different, even just like what they title themselves as like mobile surgical units, whether that be special operations or conventional, either one. They can do the surgery, but they come with like an enormous wagon load of gear, and it takes time, and they're not really as mobile as maybe they should be looking forward. So, maybe some lessons learned from your experience to the military to now flat hatting around the world. Like, how did your mindset have to change?
What you ask reminds me, in 2013, I was with the 28 Cash. And I was actually assigned, I was sliced off to the 2nd Forward Surgical Team to DSP Galan in Afghanistan. And our specific request was we need to make a golden hour offset surgical team or ghost team for the Whiteside Special Operations community. So I was sliced with them, and there was the commander and his MSC, they kept forcing us to say that we could do with a 5-person surgical team everything that could be done with a 20-person forward surgical team. Ultimately, what happened with that is I insisted that, no, if we're going to travel with less, we're going to have to do less, and we can't falsely advertise. Ultimately, that came to an impasse, and they let me go, which was fine. I actually never get a ghost mission. But what it showed me was even within the SOF community, there is this difficulty understanding that when you show up at a certain place, you're not bringing the Mayo Clinic, and you're not bringing the Mayo Clinic's resources. You have to accept that with reduced inventory, you have reduced capability.
Yeah, absolutely. Like, you can have the most experienced provider, surgeon, medic ever. You restrict their stuff, you limit what they can do. I mean, it seems kind of obvious, but for some reason, it seems like a hard idea to move across.
I think another aspect about it that's important to think about it is within the special operations community, there's always a push to, can you operate in this way? Can you operate on this platform? Can you operate in this location? Can you operate with less notice? And a lot of times I would see friction between different components of the team when a lot of times, honestly, the biggest barrier to where you can operate is driven by the surgeon. And the reason it's driven by the surgeon is, one, they think Unless I can do everything, I can do nothing. Or they think the only way I can get to do something is if I do it this way. And as a result, their care has to be thought not only to selecting the right people to go, but also has to, like, the training of the right people to go. Because nobody's going to be ready to go with a box of suture into the middle of the jungle and think they can help somebody. That takes a little time to develop.
Yeah, absolutely. So, maybe just looking back at the training you received, whether that be, just general surgery into, I'm guessing, trauma surgery, into whatever units you've been to, like, did they prepare you for that kind of mindset?
I had the good fortune of being in residency when GWOT kicked off. I actually got in trouble because I called the branch manager and offered to resign my surgical residency if they would get me to war. But my boss was actually the consultant to the Surgeon General, and he let me know that that wasn't going to happen, that I was going to graduate from residency. There would be no letting me go. But yeah, even from very early on, we all knew that we were going to go to war and that we should all be ready for it. I actually went to the residency where I went because 3 surgeons were part of the special operations surgical team. And I knew it was part of a 5-year-long interview that I had to go through. Certainly deploying first in 2005 with the forward surgical team was, I think, a really good way to kind of see how it went. And then transitioning over into special operations in 2006 was super helpful. And just learning, like, we're going to give you a whole new way to think about this. The biggest difference between that soft experience and the modern experience when you go to like the unconventional warfare environment is that your patient population is just very, very different. But with respect to the military, I think the military was fantastic training, very expensive training, and a ton of it across the mine combat deployments. There no doubt were invaluable for now. My biggest problem is, how do I prepare and train people now without those budgets, and how do I help them get the right mindset before we get into a tight spot?
Yeah, because and again, I'm not a surgeon, so obviously people have their reasons for doing the things that they do. But it seems like a given surgeon, if he's got like his own like specific trays for specific procedures, right? Like, I want 2 of this and 5 of those and 12 of these and et cetera, et cetera. When you deploy, or when you really have to be mobile, you don't really have that luxury. And you mentioned, having a certain way of doing things can hamper a mission or a case. So I guess, how did you overcome, which was kind of the culture of, you get, like, these are the things you have and you can tailor it to what you want, to now you have this small handful of instruments?
I think it's probably a number of factors. Let's see if I can articulate a few of them. One, I would say that, the first rule of medicine is kind of to do no harm. And so you end up in a situation where it's dirty, power's unreliable, you don't know the referral patterns, you're not going to be able to follow up. Basically, the whole structure that you were trained on in that moment doesn't exist. I can remember a Moscow situation in a location where I was at. I was operating. Actually, I wasn't operating. I was visiting another forward surgical element. And the forward surgical element encountered like 6 wounded children, and they operated on one successfully, but they sent 5 away. And when they sent the 5 away, my question was actually harsher than it should have been, which is unfortunately consistent with me sometimes. And that is, I just asked the surgeon, I was like, how many children have you killed by operating on them? And he's like, none. I was like, well, you probably just killed 5 by sending them out on the economy, like you said. It's like these kids got attacked at Suicide Vest terrorist camp where they were being trained to blow themselves up. It's not like they had a supporting system that's going to love them outside. So I think one way you prepare yourself is just for the hard realities of life in a war zone, and realizing that if you don't help them there now, they're stuck with wherever their disease takes them. So that's very helpful. The other thing I think that's kind of helpful to understand is a lot of times when you're on a 4-person surgical team, which means you don't have any pre-op, you don't have any post-op, you don't have any clinic staff, you don't have a PACU, it's really you. And until you hand that patient off, it's you and your team. Having so many years of experience, essentially almost a decade, I think 9 years of time in that situation, was really helpful for me to learn that if I had 60 instruments, I was probably only going to use 10 anyway, and I would do well to get down to 10 that I was going to use reliably. And if I needed one of those other 50 that I didn't have, I had to come up with a new way of doing it, which most of the time is make the incision bigger, or change something out to make it possible. And then I think another thing is what you do. I can remember a team getting in a fight, a special operations surgical team getting in a fight where the team leader promised the assault force, hey, we can provide surgery in this situation. And then the surgeon goes, no, we can't. And I watched this fight kind of play out with some significant intensity, as you can imagine. And what I realized in that moment, I was pretty young at the time, was it's not that we can or we can't, it's what can we do in that environment. So instead of thinking, oh, I'm going to cross-clamp the aorta and, do some major Hail Mary save, which you may be able to do in some places, if you reduce your overall amount of equipment, you're reducing your overall capability. That doesn't mean you're not while you add it. You just have to accept that there's going to be a shifting of what you're going to, and make sure you focus on where you can be value added.
Yeah, I mean, absolutely, that makes sense. In context, any situation is really paramount. If you're described a given scenario, what can you provide, and then that scenario changes, you may or may not be able to do the same thing. Right. So you mentioned, having to train others to kind of fit, or at least follow like some of the lessons that you've learned along the way to be more effective. If you were able to change anything about military training or even civilian training to go into that environment, what would you change?
I think what I would probably change is just the overall exposure. There's 5 billion people in the world without safe, affordable access to surgery. The global population right now is 8 billion people, and probably within the next 20 years, it's going to be mind-blowing. Our surgical capacity hasn't really expanded any, so that's going to mean there's 6 billion people without access to safe, affordable surgical care. Most of the surgical care that's being developed and all the meetings and the latest and greatest technology is really focused on how we take better care of that 3 billion people that we're going to take care of next year, next year, next year. Meanwhile, we're basically not taking care of the 5 billion and the 6 billion, and probably in our lifetimes, the 7 billion people that don't have access to surgical care. So I think that we do need to come up with ways to get these highly qualified, highly trained people to be able to apply that skill for the 5 billion people who don't have access, and then to open their eyes, mostly through reading the history books, to be honest with you, of what was acceptable in the past and what do they think they can do today, and can they also prepare themselves? Can they prepare themselves for worse outcomes, knowing that having worse outcomes is better than if they don't do anything?
Yeah, that makes sense. You mentioned, having 60 instruments and you pare it down to 10. I guess, is it just experience that you've been able to do that? Or like, how did you go about and say, I don't need 80% of what was given to me. I only need these few things. I guess, what pushed you to that? And then how did you make your decisions?
Well, I think, like, if we just use the leveling of what goes into a forward surgical team, typically 3 trucks with 3 trailers, 21 people working in 3 large tents are able to take care of 30 patients in 3 days without resupply. And from there, we went to I went into the special operations community, and that was like, okay, how do we take care of 2 to 4 patients with 4 to 8 people, but take care of them right now, far forward, massively injured people? How are we 100% for the 1%, as some people like to say? And then I switched over the ghost team, and the real question was, what were we going to take care of? And what I concluded was, for the most part, when U.S. forces in a GWAT environment get into a troops in contact situation, they usually have somewhere between 1 to 2 seriously injured and probably no more than 5 minimally injured people before they disengage. Now, that's certainly not true in all situations, but the vast majority of ticks that happen, very few people get like seriously injured. So that amount of kit went from 3 trucks with 3 trailers down to like 4 rucksacks, give or take a little bit. I think Ghost Team rolled with a couple of side-by-sides. When working in like missionary hospitals is actually pretty useful because they do a lot. It's a safe, austere environment, and you're just working with people who are just trying to take care of the overwhelming masses of people that just need health care. So you kind of see how things happen there. But what really kind of drives the smaller amount right now is, one, without any ancillary or support staff, everything you carry, you acquire, you maintain, you carry it someplace. Like, you're the one responsible for whatever it is you're carrying. Being part of a small humanitarian / Christian, maybe Christian / humanitarian nonprofit, our budget is really small. So that helps keep my inventory down for sure. And then I think the other thing about it is, what's the lift capability for whoever I'm working with? Like, if we're going to strap it on a motorcycle, 110cc Honda Wave motorcycle is not a great, it's not a great amount of lift. You think a Blackhawk is small. A Honda 110 Wave is much, much less to move your equipment, and it's just harder terrain to move it through. So I think all of those factors kind of drive it. And then another thing is, what patients are you taking care of when you're behind a terrain feature in really, really difficult terrain where the enemy has air superiority and, quite frankly, fire superiority. If they can bring it to bear, your evacuation times turn into much longer times. So as a result of longer evacuation times, we don't have to worry about being 100% for that 1%. That guy's not coming. It's different when the little bird can land on the X 3 minutes after the tick. So yeah, that kind of shapes what we have and how we look at what we carry. And then the aftercare capability, where are you recovering your patient? In the United States military, every patient who's sick is going to recover in an ICU somewhere. Versus when you're with a Christian missionary organization in a conflict zone, you have what you have. And so people can get blood transfusions and live, but they can't get 300 of them and live. So yeah, your triage is a little different.
Yeah, absolutely. So another thing you mentioned is, sometimes you're going to have to be the definitive kind of treatment for this patient because it's going to be X period of time before anybody even looks at them, let alone does anything for them. Which it kind of goes against what I was trained was like, well, just do what you have to do right now because somebody else will, they'll take them into the OR and clean up what you missed, or they'll be the definitive kind of answer for them. We're just trying to keep this guy from dying. And especially if you're going to be in a dynamic situation. Sometimes you have next to no support. Probably sometimes you do have a fair amount of support. So I guess, how do you make that decision where I'm going to do what I have to do and move on, and somebody else or myself even, I'm going to revisit this situation and clean it up and do a more finished job, versus I'm all he's got, I'm going to do it all now, understanding that probably more people are waiting a bit longer for me to do this finished job versus kind of a quick and dirty procedure.
I think what you're talking about now is like damage control resuscitation, damage control surgery versus just definitive field care. We actually have an article out now that we're hoping will get published, really defining this definitive field care for the purpose of, I don't think the U.S. Army doctrine has a good plan for the UW environment. And one thing I never realized until I started doing what we started doing is damage control methods consume a lot of resources, to include time, and they require sure follow-on. So if you ever put yourself in a position where you're not going to have the time on the backside, or you can't guarantee that person's going to see a provider again, damage control surgery, like if you don't hook people up, if you don't get them in a place where they're definitively taken care of, if they're not going to have a good outcome. So you may accept that 70% of people will have a worse outcome if you do definitive field care, if you know that 100% of those people aren't going to encounter somebody again, because all of them will have a bad outcome unless you do something definitive. I find that we are in those predicaments, and what drives the different decision making is if I'm in a place where I know that I can be sustained, that is, I'm working for the resistance, it's a place where I have access in and out, it's going to be reliable, then we can kind of use more comfortable techniques for doing that, because we know, like, we can just do what we used to because we know we'll be there tomorrow. But when you're definitively working for the resistance, one of the things that you have to do when there's 3 or 4 of you and 200 of them is submit. Like, you're not winning that discussion. And they'll also not necessarily, the guys I work with, what we say is going to happen and what we actually happens isn't always how it plays out. They may tell me what I want to hear, but I'm not there tomorrow. So I just have to be very careful to submit. And then I also have to think definitively, like, we're going to get this in a good spot where if I never come back, they're at least in a position where they should be able to heal completely. But some of that, you really have to know what context you're in, who you're working with, and then just do the best you can. It's not always easy because I may not even know the guy who's making the decisions on where I'm going to be or how I'm going to work.
So, like, when you're talking about where you're going to work, obviously you're going to need some kind of space, right? They can't put you in, like, a soup cupboard, right? Me and the patient aren't going to fit. So how do you go about maybe describing what kind of requirements you're going to need, either space-wise or support-wise, to a resistance guy who doesn't have a hell of a lot?
Sure. A lot of times they're pretty sensitive about that, actually. Like, they'll talk to me. I have it dialed in. I'm 100% sure that if you put me on something about 10 feet long and about 8 feet wide, and if it's at least 7 feet tall, we can do effective surgery in that environment. We can make it a little tighter, but if I was being dreamy with the kit we roll with, if it's 10 feet long and 8 feet wide and 7 feet tall, we can do what we need to do to do surgery in that environment. Communicating with them, like, a good example is places we've operated, but I've operated in the last 3 months. I've operated in a cave. I've operated in a dirt room, a dirt-floored schoolhouse with a leaky tin roof with no electricity and no water. I've operated in 2 people's living rooms. That's no climate control, no glass on the windows, kind of home. I've operated in one clinic that was just a community clinic that we drove to and set up an OR in the clinic and operated there. And then we've operated in a medical storage shed where we could generate that 10 feet by 8 feet by 7 feet, and we were able to work just fine. Learning that you can operate in that space really helps shape, like, what you're going to do and how you're going to do it. Being able to operate without power, that's pretty doable. Being able to operate without water, that's actually more challenging.
So I imagine, these environments, especially the austere environments where you're having to work, probably wouldn't match with Western thought processes on sterility. I guess you're going to have to make cuts just because you don't have the stuff, you don't have the time, you don't have the personnel to do it, I'm going to air quotes, the right way. But what are, like, the bare minimum things that you're like, we cannot really move forward without causing further harm to this patient just on sterility alone.
Now, I think if someone's bleeding to death, or if somebody has soilage to death, if somebody has a process by which they're going to die if we don't do something, you can handle a lot of dirt for that. If we have sterile techniques and processes, we follow it. It's in America, we definitely watch our sterile technique and stuff very, very closely. I've seen people in other countries, a number of other countries, where they'll put on their sterile gloves, pull their hands through, and then smooth down the front of their gown or whatever, and you're like, kind of defeats the purpose. For the most part, we do surgeries with just gloves. Paint it with, typically our prep will rub the area with alcohol until the cotton no longer is dirty. And once all the dirt is off the skin, then we prep it with iodine, and then we do our operation. A lot of times we put towels down just to keep the instruments as clean as possible. But yeah, we tolerate a lot more non-sterile technique. Like, I'm actually kind of sheepish about it. The problem with sterile technique is it requires a lot of cube and weight. As somebody with a hemothorax or a hemopneumothorax with 1,500 cc's of blood in their chest, if you put a chest tube in them non-sterilely, that 80% of the time may stop their bleeding and get their lung up, and they're off to the races, and they'll heal fine. So it would have to be a pretty dirty environment before I just kept letting them bleed in their chest. It's hard.
Yeah. I think somebody's bleeding to death. I feel like I'm pretty confident that I'm going to go do something, and then infection is going to be a living person kind of problem that we'll have to deal with, or I'll send them to you and then you can deal with it. But we always see, pictures of the ghost team or some kind of forward surgical or austere surgical unit, and they're wearing t-shirts, they got a baseball cap backwards, and they're scrubbing into surgery, and you compare that to, the West, you're like, well, did they put any thought process into things that they're willing to accept, or are they just doing whatever they want now?
Yeah, what's interesting is when you roll with 3 trucks and 3 trailers with the goal of taking care of 30 patients across 3 days without resupply, you can do sterile technique reliably. Like, that's not a problem. When you take care of 15 patients with 4 suitcases, 20 hours, 48 hours away from home base with no resupply until you return, you have to ask, like, this kid, this, 4-year-old with an incarcerated hernia, like, what I don't do is I won't put mesh in. I won't increase their risk from infection, but I'll still try to give them a repair because I'm the only surgeon that's going to operate on them. The place I'm often at now has about 1.6 million people and less than 10 surgeons. They access to care. The price for them traveling a day may be the price for you flying from North Carolina to Los Angeles. It just costs that much for them to move because gas costs that much for them to move. So when I realized this may be their only shot, if we can do safe anesthesia and we can do safe surgery, we'll take the risk of an infection. So far, we haven't had any terrible, terrible wound infections out of 200 patients. that we've operated on. And for the most part, my follow-up is pretty poor, so I don't know how reliable that is, but I know that the people keep having me come back.
That's a good sign. Yeah. And obviously you're probably dealing with a different population than maybe a Westerner, with our constant flow of antibiotics, and sterility also tends to breed some pretty nasty bugs.
Yeah, typically the patients there, one thing about it is there's definitely a difference in, there is no spread of infection in the hospital when you're operating in the schoolhouse and the home and the clinic. Like, it's a very different environment. So we don't select out the same. A lot of times, and I don't know if there's anything real to this or not, but the people are living in the environment that they're recovering in. So there's no change in their environment, really. They're not coming to the hospital where they're getting introduced. Like, I do their surgery in their living room and they sleep in their bedroom type of thing. It's very much, I think Halstead took his mother's gallbladder out on her kitchen table in the turn of like the 19th century. And the reason they would operate in people's homes back then is because hospitals were so dangerous for infection. I don't really know how all that plays out. I know I don't put in any foreign bodies. The only thing that I'll put in is a permanent suture. I like to put in permanent suture that's at the lowest risk for infection. So we try to prevent bad outcomes. If we're worried about the wound, we'll leave the wound open. Simple techniques like that, yes, to a place where the people are happy to get care.
Yeah. Now, you mentioned anesthesia, if you have effective anesthesia. Do you have an anesthetist that comes with you, or are you running the show as well?
Yeah, so there's another general surgeon that works the most with me. I've had a few other volunteers that have worked with me. One of them has been a anesthetist. He's great. It's really wonderful to have him. When I first started, I was just using a local with just blocks. And then I figured out there's a book called Anesthesia Off the Grid. This is a great book, $5, $6. Great book, really, really useful. I read it so many times, the binding's fallen apart on it. But I started using ketamine, which I got through the black market. After that, I found some spinal equipment. We started doing spinal, so we added that. And now if I'm a place where we have the medications, I'll actually do general anesthetic as well. And typically, the surgeon that most of the time volunteers with me, we split the cases. So if that surgeon feels comfortable doing the surgery, they do the surgery and I do the anesthesia. If that's not the case, then I do the anesthesia, or then I do the surgery and they do the anesthesia. So, yeah, we're actively looking for someone who wants to do anesthesia for us.
Right. Oh, there you go. When it comes to this austere surgical care, let's say you have I would say new to austere type medicine physician, provider of some sort, right? They want to come help. They want to come do what you do. What advice would you give them?
Yeah. It's interesting. Lou Kolodny was part of 2nd Battalion Green Team, 5307 Provisional in Males Marauders. He came out of 1 year of internship in, I think, 1940 or 1941. And shortly thereafter, he did his first X-lap when Males Marauders engaged the enemy as they were entering from India into Burma. He did an X-lap with ether alone, with some Ranger medics or some 5307th medics. And it is bizarre to me that a guy in 1940 with his level of training has more courage, even though he is much less trained, has much less understanding, much less technology working for him. But he will take a risk and move forward and save a life more likely than our better trained, better educated physicians today. And so the first thing I would say is make sure you go with courage. Make sure you think about, if I do nothing, this disease continues on this course, which will be a fatal conclusion, and the absence of doing anything only means you assisted the disease. There's no glory in that. So have the courage to make a mistake. Have the courage to start and see where starting gets you. Most of the time, there's a place to stop if you find yourself in a bad spot. The second thing would be you need a lot less in your backpack than you do in your head. And the most important thing to have in your head is not all the right answers. It's basic, simple principles. Like, I shouldn't leave dead tissue in the wound. Dirt inside or deep to the skin is a bad thing. Take it out. If it's bleeding, I should stop that. So just these basic principles that you don't have to know all the data for. You don't have to have how many standard deviations or what's the outcomes. Just very simple stuff that can get you to somewhere to be effective where there is no doctrine. And then you've got to figure out, okay, what are we going to take? How are we going to take what we need? And a lot of is going to be trial and error. So go try stuff and make errors. Just keep going.
Yeah, makes sense. Any final thoughts, Jason?
No, I hope this is helpful to you, and if you need anything, let me know.
I really appreciate it. Would you want to talk about your organization?
Yeah, we just have a small nonprofit. It's called the Four Winds Professional Guild. It's a faith-based organization that really works on how do we take care of people in need, specifically the church in need, where we can create a safe spot for us so that we can provide expertise for them that they need.
Awesome. Where can I find that?
We can find it online at www.guild.org.
Perfect. Well, again, Jason, I really appreciate you jumping on.
How'd I give them?
Have a good one. That's it for today's podcast. Make sure to go to our website, www.prolongedfieldcare.org. Check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee, links in the description below, and stay on the bleeding edge of combat and austere medicine. This is Dennis for the PFC Podcast, out.